Welcome to the Virginia Hospital and Healthcare Association's Patients Come First podcast series. Podcast episodes are available on VHHA.com and on popular podcast hosting apps, including Apple Podcast, Amazon, Spotify, and many others. We're a member of the Public Health Podcast Network, the Virginia Audio Collective, and the World Podcast Network. Podcast episodes also air on Sundays at noon at 100.5 FM, 92.7 FM, and 8:20 AM across Central Virginia, 1650 AM in Hampton Roads, 105.1 FM and 1050 AM in Lynchburg, and Wednesdays at 1 PM on 93.9 FM in Richmond. Please send questions, comments, feedback, or guest suggestions to pcfpodcast@vhha.com. Again, that's pcfpodcast@vhha.com. And today we're pleased to be joined by Dr. Rachel Moon, a pediatrician and safe sleep expert at UVA Health Children's Hospital. Dr. Moon joins us for a conversation about her work, an examination of safe sleeping trends and considerations for infants that has prompted federal legislation and more. So with that, welcome to the show, Dr. Moon. Thanks for being with us.
Thanks for having me today.
Well, it's our pleasure. We appreciate you fitting us into your schedule. It's our custom to start these conversations with just a deeper introduction of our guests. As we noted, Dr. Moon, you're a pediatrician and the Harrison Distinguished Professor of Pediatrics at UVA Children's Hospital. You've done extensive research on sudden and unexpected infant death. You earned undergraduate and medical degrees at Emory University and completed pediatrics residency at the Children's Hospital of Philadelphia before spending several decades in clinical and leadership roles at Children's National Medical Center in Washington, D.C. You're also a recognized researcher in the field of sudden unexpected infant death. Those professional highlights, I'm sure, are just one facet of your unique personal story. So beyond those few details, Dr. Moon, what should people know about you?
That was pretty extensive. Between residency and going to Children's National in Washington, D.C., I was actually a pediatrician in the U.S. Air Force for 5 years. And that's really where I cut my teeth on how to take care of patients and how to talk to families and thinking about how can I convince families or encourage them to do anything healthy, whether it be safe sleep or whether it be, you don't have to give your child candy every single day, to put your child in a car seat, to use bike helmets, all of those kinds of things. I tell my students and my residents that, what we do every day is a sales job. We are trying to convince families in the ways of health, and we have to sell health to them. So I think that that's kind of an important thing, and so that's what I try to do every day.
Well, I really appreciate how you frame that you're trying to sell health, healthy behaviors, healthy principles to patients and families. It's a really good way of putting an interesting framing on the concept of the role of clinical providers. A moment ago, we mentioned that your research has focused on sudden unexpected infant death, or SUID, which claims the lives of 3,400 babies in the U.S. each year, and it may be attributed to suffocation in some cases. I have a 12-year-old son who's now, today actually, in his first day of 7th grade, but I remember like it was yesterday, the fear my wife and I had about SUID and how obsessive we were about monitoring his sleep in his crib. And so, just with that background, I wonder, as a baseline, Dr. Moon, if you can share a general overview of what sudden unexpected infant death is and what factors may contribute to it.
So sudden unexpected infant death is really what it sounds like. It's when an infant, so somebody who is younger than 1 year of age, dies suddenly and unexpectedly. And we know that there are many things that can contribute to this, whether that be genetic, whether that be physiology, whether that be environment. There are a lot of different things that feed into this. But the basic concept is that for some reason, the baby cannot wake up when they are having a problem with oxygenation and with breathing. And most of us can do that, and we do that multiple times every night. But there is something about some of these babies where they can't do that. And we don't know just from looking at a baby who's going to have a problem and who's not going to have a problem. And so then you have this baby who can't wake up if they're having problems with oxygenation, and you put them in an environment where they could have problems with oxygenation, with getting enough oxygen. And that would be like putting the baby in an environment with soft bedding or with another person or something like that where their airway is not free and clear. And then when they can't wake up, then that is what triggers this kind of a vicious cycle, and then they eventually die. And this is probably one of the reasons why we say put babies on their back, because we know that when babies are on their stomach, they sleep more deeply and they're harder to wake up, which is what every single parent and every single child care provider wants, because they want the baby to sleep deeply and for a long period of time and not wake up frequently. But that, ironically, is what the problem is with that. So that's why we want babies on their back. That's why we want babies to wake up frequently. I say that a good sleeper is not a baby who can sleep fully through the night for 8 hours. I consider a good sleeper a baby who wakes up frequently, and they do have to wake up frequently to feed. They wake up frequently, and then they can go back to sleep on their own. So that's kind of in a nutshell what, many, many years of research has told us.
Well, I appreciate that overview, and that's actually really interesting context, which perhaps turns on its head the conventional wisdom, this idea that a good sleeper for a baby is a baby that sleeps through the night. And you're saying that actually may not be how one would define what a good sleeper actually is, because the baby has to get up to feed multiple times and things along those lines, as you said. And then just out of curiosity, we mentioned that you did your residency at Children's Hospital of Philadelphia, and then you mentioned working in the Air Force after that. How did you come to pursue this area of clinical practice and research focus, Dr. Moon?
It was truly an accident. After I came back from my first maternity leave, one of my colleagues said, "Have you ever noticed that when babies sleep on their backs, they do things like crawling and rolling over later?" And this is right after the Back to Sleep campaign started. And I said, "Oh, that's interesting." And then I was noticing that too. And so we decided that we would look at this. And so we interviewed parents on a monthly basis and asked them what their babies were doing in terms of how they were sleeping. And by how, I mean what position they were sleeping in. And then what they had achieved in terms of their developmental milestones that month. And what we found out was that babies who sleep on their backs, they roll over a little bit later, they crawl a little bit later. None of this is abnormally later, but just a little bit later. But then what happened was that a lot of parents couldn't tell us what was happening in the day in terms of the baby's sleep habits because the babies were in daycare. And so then I said, well, I wonder what's happening in daycare. So we interviewed daycare providers, and we found out that 75% of them were putting babies on their stomachs to sleep. And so then, obviously, the next question is, well, if that's happening, then how many babies are dying in childcare settings? And it turned out that a lot of babies were. And so by that time, I had been doing this research for about a year or a year and a half or 2 years maybe, and I was kind of hooked on this. It's like, this is really a fascinating disease or condition, and that's how I kind of got into this topic.
Well, I appreciate you sharing that background. And just for the context of listeners, Dr. Moon just referenced the Back to Sleep campaign. That was a public health, or I should say is a public health initiative that encourages parents and caregivers to put babies to sleep on their backs to reduce the risk of sudden infant death syndrome. This campaign began in 1994, and one of its initial goals was reducing the percentage of infants put to sleep on their stomachs by 10% or less by the year 2000. And then, Dr. Moon, as part of your work to promote safe sleep, last year you were among a team of clinical investigators awarded a National Institutes of Health grant focused on implementing strategies to decrease sudden and unexpected infant deaths through educational efforts targeting new mothers at more than a dozen birthing hospitals. I wonder what additional background or insight you can share about the grant, the project, and any findings or progress that's been achieved in that program so far.
Well, my research has focused on what parents do at home with their babies with regards to sleep, and then why they do that. What drives these decisions, and why do they make the decisions that they make? And what we've learned is that there are a lot of misconceptions out there about safe sleep, and there are a lot of things that people are hearing from other people and from people in their networks about safe sleep. So, for instance, a grandparent might say, "Oh, we put all of you on your stomach and you are all fine." Or if you put a baby on their stomach, they're not going to choke when they spit up. And these change your attitude about these behaviors. And so then when a doctor tells you something or a clinician tells you something and you're hearing something else from the people around you every day, then that's going to change your attitude and that's going to change your idea of what everybody around you is doing. And you want to do what everybody else around you is doing so that people don't judge you. And that's called the social norm. And we know that social norms and attitudes are very, very key in what people do every single day of their lives, not just for safe sleep, but for everything. And so the first intervention study we did was we sent families videos to combat these misconceptions and to try to change these attitudes about safe sleep. So we showed them videos of babies that show that with their anatomy, it's actually harder for them to choke when they're on their back, to change that attitude. And what we found was that we were able to increase parents who actually said that they followed the safe sleep guidelines. We were able to increase that by 10 percentage points. And so now we're taking that and we're trying to figure out what is the best way to get this video program out to as many people as we can. So we are working with 20 different hospitals and looking at different strategies to do this. Can we use QR codes that parents can scan to get them engaged in this? Do we have to have nurses or clinical staff involved to encourage them to do this? What is the best way to get parents to sign up for this video program and to learn about these misconceptions and how to change these attitudes? We're also, in one of our grants, we're also using Facebook parenting groups to try to change what people are being told from the people around them and to establish kind of new social networks for them to see if that makes a difference as well. So we're trying a whole bunch of different things, but all of it is trying to really sell the message of safe sleep and to try to change these attitudes and try to improve these norms so that people have positive feelings about safe sleep and so are more likely to do it.
Well, it sounds like important work and certainly a number of different approaches being taken to convey that message about safe sleep best practices for infants. In addition to that, there's also been action on the public policy front as it relates to this area. In 2021, Congress passed a law restricting the manufacture, sale, and distribution of certain crib bumpers and incline sleepers for infants up to 1 year old. Again, referencing my own parenting, I remember these items being sold in popular baby stores when our son was born in 2012. The bumpers are considered a potential health hazard for infants. Now, just earlier this month, August of 2024, there's newly filed federal legislation that would ban weighted sleepwear and blankets for infants 1 and younger. These weighted blankets are certainly for older people, not infants, are, in my own observation, I would say are more commonplace in the market. One imagines that this legislation is also motivated by concerns that these products could restrict breathing or be potentially harmful for infants and newborns. So, Dr. Moon, from your vantage, what can you tell us about the evolution of the public policy in this area focused on infant well-being?
So public policy, what we have tried to do, particularly with regards to safe sleep, is to look at the data. So what is the evidence behind this product? If there is evidence out there. And so, for instance, for the legislation about the bumper pads, we know that there are different mechanisms by which babies die with the bumper pads. So they can get smushed against them, they can get stuck in between the mattress and the bumper pad, or they can get strangled on the straps. And we also know that bumper pads actually don't do anything to prevent serious injury. So when you take those two, you want to try to look at, well, is any little advantage of this, is it worth the potential harm? And so we also do this with weighted products. One of our concerns is that for babies, particularly newborn babies, their rib cage is not bone, it's cartilage. And so it doesn't take a whole lot to compress that rib cage. And when you compress the rib cage, it makes it, you're compressing the lungs, and it makes it harder for the baby to breathe. There are no safety standards for a lot of products that are out there, including weighted blankets. and included weighted blood gains for babies. And so if you have even just a pound of weight in there, that is a lot of weight. That's more than 10% of a newborn's body weight for a typical newborn. And so we had a lot of concerns about this. There's only been one published study where they took 16 babies whose parents had dependence upon opioids, and for 30 minutes they had them with a weighted blanket, and for 30 minutes they had them without a weighted blanket. And they had them monitored. The study doesn't say if the babies were asleep or awake. It showed that there was no difference in their monitor settings, but that was only for 30 minutes. And sleep is one of those times when babies are unsupervised for several hours at a time. And so to have no data on a product that's potentially, from a physiologic point of view, could have tremendous impact was very concerning to us.
Well, that's really interesting perspective. You noted a weighted blanket that weighs 1 pound. For a newborn, that could be 10% of their body weight. And so that's, again, an interesting way to think about that and to frame that. And what that could potentially mean for an infant sleeping, as you said, unsupervised for an extended period of time. So that's really great perspective there. Dr. Moon, I want to thank you for spending some time with us this morning and for sharing your expertise. Before we let you go, we do have a tradition here on the podcast to wrap things up by asking our guests a pair of fun questions to close things out. To keep things interesting, we have a list of 10 mystery questions from which you can choose. So if you want to give us two numbers between 1 and 10, we will ask you the corresponding questions.
4 and 7.
Okay. Number 4. Which, if any, of the following things do you consider most plausible? Bigfoot, Loch Ness Monster, or UFOs and aliens? If none of those apply, but you believe in something else along those lines, please share what it is.
Okay, you said Bigfoot, Loch Ness Monster,
UFOs and aliens, or something else supernatural.
UFOs and aliens.
And why do you think that's most plausible?
The universe is so huge that just seems very plausible to me, that there could be another planetary system that has life on it.
I agree. The universe is vast. It strains credulity to believe that there is nothing else out there other than us. And then you selected number 7 as well. And that question
Correct.
is, if you could choose one superpower to have or any one skill to instantly master, what would it be and why?
I would like to snap my fingers and be someplace else.
So teleportation.
Yes.
Save money and the hassle of airline travel, I suppose.
Exactly. And then, I love to travel, but I hate the traveling process.
I use that line all the time. I say to people, vacation is great, traveling is horrible. So
Yeah.
Well, listen, I appreciate you being with us and sharing some of your insight and your wisdom with us. And with that, that's going to bring us to the close of another episode of the Virginia Hospital and Healthcare Association's Patients Come First podcast. If you like what you heard, please make sure to leave us a 5-star review on Apple Podcasts and subscribe so that you know when new episodes are available. And we want to once again thank our guest, Dr. Rachel Moon of UVA Health Children's Hospital, for joining us today. So thank you.
Thank you so much.